sir. Sir is my ophthalmology guru. He's the best teacher I've ever seen. Thank you, sir. So, last but not the least, my topic is on yet another important section of neuro-ophthalmology, that is the pediatric neuro-ophthalmology. So, I'll be talking about pediatric optic nerve head disorders. So, why do we need to know? The importance of catching these children young are because many of these pediatric optic nerve head disorders are quite misleading, and sometimes there can be a delay in diagnosis. We have to catch them young because they are in the neuroplastic age group. So if you can correct their refractive errors and if you can correct the superimposed amblyopia in this age group, at least the visual prognosis is better in these kids. And also these optic nerve head disorders gives a clue towards the underlying systemic condition. So careful disc evaluation in a kid gives a lot of clue for the underlying conditions. So let's know what is a normal disc. So normal disc in a kid usually is pink colored, more of vertically oval than rounded as you see in adults. The average cup disc ratio is around 0.3. Of course it is variable. It is slightly elevated from the surface, and the RNFL layer is quite thicker in kids as compared to that of adults. So one more clinching point here I would like to say is whenever you're examining a child, you're holding the eye tight and you're trying to force the child, the child is crying, sometimes you get to see a pale disc. So that is because of the pressure on the eyeball or because of a crying child. So you should always be careful while seeing the disc of a child. So these are some of the topics which I'll be discussing today. So for understanding point, I've divided it into congenital and acquired optic nerve head disorders. Let's first discuss some of the normal variants of a disc. So suppose you see this picture in a patient. Sometimes even patients are referred with these conditions thinking it might be a cotton wool spot or a vascular occlusion, because a large myelinated nerve fiber is sometimes confusing and misleading. So the clinching points here is it will start at the disc. Usually it has a very feathery margin at the end. So it can be present at the disc or it can even be present elsewhere also away from the disc. So it will usually appear as a white, elevated or yellowish lesion. So it is normal in 0.5 to 1% of normal population it is seen. Sometimes it can be associated with myopia and amblyopias. So it is asymptomatic, you don't have to really do anything, but always make a note of any myelinated nerve fiber, the location and the size, because the importance lies when there is a disappearance of the pre-existing myelinated nerve fiber, which can happen in any of the demyelinating disorders. So presence is not of much importance. If it disappears, then that is more important. So optic nerve head drusen, it is a great mimicker of optic disc edema. Many a times kids gets referred with this blurred disc margin, suspecting disc edema. They would have undergone a lot of investigations before coming. So these optic nerve head drusens are nothing but a refractive calcified nodules which are seen on the surface of the optic nerve head. So superficial drusens are quite easy to identify, but a buried drusen, which is quite common in kids because they are still underlying, as the age advances, the drusen can come up. So buried drusen is sometimes confusing. It is important to differentiate between a true disc edema and a pseudo disc edema. So some of the clinical signs where you can actually differentiate between a true disc edema and a pseudo disc edema are, so the top picture shows a pseudo disc edema. Usually it will be an elevated lesion, blurred disc margin, and you can see that the capillaries, if you follow a capillary over the surface, usually it will be continuous, and there won't be any much of vascular tortuosity as you see in a true disc edema. As compared to that of the lower picture, you can see the blurring of disc margin is there, vascular tortuosity is more. You can see some of the flame-shaped hemorrhages, and you can see disappearance of capillaries. They get buried under the edema in a true disc edema. These are some clinching points clinically. So the more diagnostic are these three investigations to differentiate between a true and a pseudo disc edema. If it is a superficial drusen, you can pick it up with fundus autofluorescence, where it gives a bright hyperfluorescent foci over the disc. The easy way of diagnosis is a B-scan. B-scan can show a highly echogenic foci over the disc. The best test you can do to identify a true and a pseudo disc edema is OCT, because OCT gives a clear-cut diagnosis. Both superficial as well as buried drusen can be picked up with this. So it gives a hyperreflective core with the surrounding hyperreflective borders. With the advent of enhanced depth OCTs, even a buried drusen can be picked up easily. Moving on to congenital optic nerve head anomalies. So this is a fundus picture of a child. You can see on the right side it is a normal looking disc. In the left side you can see a smaller disc, and you can see a peripapillary pigmentation, and the vasculature, if you see compared to the disc, they look little larger and more tortuous. So what is this condition? So this is a case of optic nerve head hypoplasia. So optic nerve hypoplasia is quite often missed. The incidence is more than what we actually diagnose. And whenever you see a optic nerve hypoplasia, always ask the history. There will be history of mother having a use of a teratogenic drug, alcohol abuse, or tobacco usage during pregnancy, or there can be a gestational diabetes. And if you see optic nerve head hypoplasia, there can be associated conditions such as microphthalmos, aniridia, coloboma, nystagmus, and strabismus. So always look into the systemic associations. So they can have a lot of neurological anomalies. It can be absence of septum pellucidum, anencephaly, cerebral malformations, and dilated fourth ventricles. Always you should do for a endocrine workup, because they are associated with pituitary hormone abnormalities. So you should always look for de Morsius syndrome. De Morsius syndrome is a triad of optic nerve hypoplasia, absence of septum pellucidum with pituitary hormone abnormalities. So whenever you see a child with optic nerve hypoplasia, do these workups. Do an MRI to find out the underlying malformations in the brain, and do an endocrine workup, which includes all the pituitary hormones, that is the fasting morning cortisol, glucose level, TSH, and prolactin levels. So you can do some of the optic nerve hypoplasia are associated with genetic background. So you can go for a genetic analysis. The common gene associated is HESX1. Younger children, you can do a sexual hormone assay, because you can give a prediction that they can have a sexual developmental delay by doing these hormonal assays. So here is an excavated disc, large excavated disc, radial vessels, peripapillary hypopigmentation with a central glial tuft. This is called as morning glory disc anomaly, because it resembles a morning glory flower. So this is a sporadic condition. The visual acuity usually is relatively poor in most of the cases in this morning glory disc. Whenever you see a morning glory disc, look for these ocular associations. They can have optic nerve calcification, glial tuft, microphthalmos, and sometimes they can end up with retinal detachment. Systemically, all the morning glories will have midline anomalies. So you can see that they have a widely shaped, widely spaced orbits, hypertelorism, they can have cleft-lipped, cleft palate. Even in brain there are midline anomalies. It can be encephalocele, corpus callosum agenesis, and Moya-Moya disease. Moya-Moya disease is a condition where you see narrowing of the cerebral arteries. So whenever you find a child with a morning glory disc, do an MRA to find out this Moya-Moya disease. So of course optic nerve head coloboma is also quite common. Whenever it is associated with a choroidal coloboma, it is quite easy to identify. Isolated optic nerve head colobomas are quite confusing. Sometimes it can be mistaken for a glaucomatous optic atrophy or a glaucomatous nerve damage. So it is always important to identify these conditions. So any optic nerve head coloboma can have associated other colobomas, that is iris coloboma, there can be choroidal colobomas. You can see a notch in the lens once you dilate the child. They can have thin vascular membranes which can lead to retinal detachment, and also macular holes. These are the ocular associations. Systemically, there are a lot of syndromes associated with coloboma. If you see a child with hearing abnormalities, genitourinary malformations, then think of CHARS syndrome. They can also have cardiac anomalies. And one more syndromic association is renal coloboma syndrome, where then can have renal failure. And Aicardi syndrome is child can have, again, a lot of cranial malformations. They can present with infantile spasm, developmental delay. So whenever you see a child with optic nerve head coloboma, you should refer them to a pediatrician, a neurologist, do a renal workup, and also MRI and echocardiogram. These are all important. These are other common anomalies which we find, that is the optic disc pit, which is usually asymptomatic, but they can present with serous macular detachments at later age, third or fourth decade of life. So it's important to make a note of it when you identify it as in a kid. Tilted disc is when the optic nerve enters the optic nerve head in an oblique manner. It gives a tilted disc. Tilted disc can sometimes be misleading. It can be confused for glaucomatous disc damage or myopic disc. Moving on to acquired optic nerve head anomalies, I think most of the topics have been covered. I'll be just talking about the pediatric perspective of all these conditions. So pediatric optic neuritis, as sir already told, how is it different from adults? Adults, as you said, it is like more of a unilateral condition, more in females. Here, in children, it is more of a bilateral presentation. Usually, it's a profound loss of vision. Vision will be either hand movements or counting fingers, PL plus. It will be like a profound loss of vision. So pain on eye movements is quite typical in adults, but it is very rare in children. They don't present with this typical symptom. Disc edema is the common presentation. We don't see much of retrobulbar neuritis. It is more of a disc edema. Usually they respond very well for steroids. So common cause here is post-viral. So post-viral infection and post-vaccination, you see a lot of optic neuritis happening. So with advent of a lot of investigations as we are doing, more of immunological workup, we see a lot of cases presenting with neuromyelitis optica and NMO-related spectrum disorders. So whenever you see an optic nerve, long segment of optic nerve involvement with chiasmal involvement, and the visual, the response to steroid is poor, that is when you think of NMO. So you have to do an extensive workup for that. You have to refer the child to a neurologist because they might need immunosuppression. And the other one is the MOG, again relatively rare than NMO, ADM and multiple sclerosis. These are the other common causes which you have to think in a pediatric optic neuritis. The next, coming to the management of optic neuritis, do a thorough ophthalmic evaluation, color vision. In an uncooperative child, you can do a VEP and OCTs and visual fields in a cooperative child. Never to miss with MRI with contrast, do a brain orbit as well as a spine MRI, because there might be demyelination even in the spine, especially in NMO cases. Antibody assay has to be done for NMO and MOG, and of course, a neurologist workup is required for all these cases. Disc edema in child, as I already told, always differentiate between a true disc edema and a pseudo disc edema. So common cause for disc edema in a child is IH, hydrocephalus, space occupying lesions, infections, inflammations, and some of the medications. So never hesitate to do an MRI even with the slightest doubt of disc edema. So optic atrophy, as already discussed, it's a sequelae of previous optic nerve insult. So in children, the common causes with survival of more premature children, more of perinatal ischemic insult, that seems to be the most common cause for optic atrophy. Not the complete optic atrophy, at least the segmental optic atrophies are common in these cases. Of course, hereditary causes are also common. So we have to identify whether it's a one-time insult or a progressive condition. So the management starts with thorough history, maternal history, birth history, and then of course if there's a family history, do a gene panel workup for optic atrophy, heritable disorders. Most of the children with optic atrophy can have an associated cortical visual impairment. So addressing this condition is very important in a child. So you have to enroll the child in vision therapy, and also you have to help them with their education with low vision aids and also assisted education. So to conclude, taking a thorough detailed history is important. A thorough systemic workup is very important. So diagnose them early and treat them early, and it requires a multidisciplinary approach. Thank you.
Thank you, Amrutha. Very nice